you are the director of the Center for Comprehensive Venous Care.
Yeah, that part too.
What does the H stand for? UH hospitals.
University Hospitals, Cleveland Medical Center. It used to be simpler when it was just case.
So University Hospitals.
Cleveland Medical Center.
And director of the Center for.
3 minutes to start.
Yep.
Who will be the first presenting?
Jess will be the first, but I'm going to just introduce everybody. And
Okay, great.
yeah, so, but Jess goes first because she's just gonna, she's awesome. She works with me and knows how it is to see pain patients. So she'll start with that, and then what I'll do is I'll just talk a little bit about etiology, and then we'll go into emergencies.
Great.
And then I figured what we would do is, we'll leave lots of time for discussion. And then at the very end, we'll, hopefully Gloria will be on and she can introduce the Spanish session. Do you have the date for that, just in case she's not able to make it?
Oof, let me double check that. I think it's
I was on the last one, but the Spanish one, but I didn't understand a damn word. Jess, you look so pretty.
I'm like trying to stack pillows up to make my computer in a good level.
Where are the kiddos?
Charlotte, my baby, like 8-month-old baby's sleeping, and my son's with my husband. So at least one's sleeping.
That's good. Well, it's 7 o'clock. Hi, Gloria.
Hi there, can you guys hear me? Sorry about being late.
No, you're perfect.
I just made it through. All right, nice to see you all. Hi, Jessica. Hi, Karen. So nice to see you all.
Nice to see you all.
Is Victor there? Okay, hi, Victor. Nice to see you too.
I'm in the back. I'm always in the background.
All
Great
right.
to see you. Everything is okay. You must start it.
You started it or no?
Yes, 1900 already.
Okay, then I think we're ready to begin. I would like to welcome you to our second set of webinars, done both in English and Spanish. VLU is dedicated to education, and we are so happy to have everyone here tonight. I am here with my friend and my colleague, Dr. Gloria Salazar, the Vice Chair of Diversity and Health Equity at UNC. Gloria, would you like to introduce our guests?
Thank you so much, Kathleen. It's a pleasure to be here on a topic that is really important to me and all of our practices about pregnancy. And it was great pleasure that I would introduce both of our amazing speaker, Jessica, Pludrzynski, I hope I can say your name right, from St. Peter's Health Partners, and Karem Harth. She is at the University Hospital Harrington Heart and Vascular Institute. And we will be discussing various topics in pregnancy, venous disease in pregnancy. So thank you so much for your participation. And to get us started, we are going to have 2 talks and then questions at the end, and we're going to be all participating as moderators. And please, so for the participants, if you want to put your question, just do it throughout the lecture, and then we can address it at the end of the lecture. So we will get started with Jessica. And so do you have your PowerPoint presentation?
I do. Let's see.
All right.
Let's try this. There we go. All right, so my name is Jessica Pludrzynski, and I'm a nurse practitioner with St. Peter's Vascular Associates in Troy, New York. We are part of an IAC accredited vein center, and I help patients be set up for vein procedures in our office, and also I see patients and follow up after their vein procedures. This presentation's on venous disease in pregnancy. This is a topic I have knowledge about from my professional life, but also my personal life, because I've been pregnant 2 times in the past 3 years. So I hope you enjoy my presentation. So I just want to start off with a quote here about pregnancy. Why is venous disease or having problems with your veins so common in pregnancy? It's all about pressure. So every mother is aware of these effects in the bladder during pregnancy, causing them to urinate more often and with less control. The same thing happens to the blood vessels going through the lower abdomen, pelvis. They are squeezed by the growing baby, making blood flow more difficult. So with the growing placenta and uterus and fetus, it's causing pressure on the blood vessels, restricting blood flow. So veins are the pathways bringing blood back up to the heart, and with the pressure of the baby, that is restrictive. Slide. So how do you know if you have this issue? Typical symptoms would be heaviness, aching, pain. It's typically worse towards the end of the day. How would it look? I did place a photo here of some varicose veins. There is a wide variety in presentations of varicose veins. Some people have many, some just a few. Some folks will just have swelling as their presentation. And it's not unusual to have an increase in spider veins. So this is really, something I want to go into detail about is compression. So for treatment of varicose veins or venous disease in pregnancy, compression is really the mainstay of treatment. So the strength you would look for is 20 to 30 millimeters of mercury. So if you're shopping for these, those are the numbers you're going to look for. And they come in a few different options. So knee high is my personal favorite. I just think they're the most realistic for most people, just due to them not being up to the thigh, not being a full pantyhose. They fit comfortably under clothing and are pretty discreet. So that's my personal favorite. Highly recommend those. I wear those at least 3 days a week. I wish, I could say I wear them every day, but I don't. 3 days a week. Thigh highs are good for people who have varicose veins behind the knee, because the knee high sometimes presses into the behind the knee area. And thigh highs, unfortunately can roll down. So that's the downside of them. There are adhesives that you can purchase to adhere the thigh high to the skin, but, that can be a lot. So, personal preference is a big thing when it comes to compression. You have to try and see what works for you and what feels comfortable. There's also a full-length pantyhose option, which covers the most surface area, but can be pretty restrictive and very warm during the summer months, especially when you're pregnant. So, those are some of the options that are out there, and they help compress the veins and help support that return of blood. Another comment I have to make is towards the end of pregnancy, it's normal to need a little help getting the stockings on and off. And if you're going to purchase these, your provider can give you a script, and they typically are covered by insurance during pregnancy. And it's important, if you're going to order them on Amazon, to look at the size chart. Each stocking will have a size chart, and there'll be 4 different measurements: ankle, calf, below the knee, and then usually there's a measurement for length of the leg. And it's important to follow those when you're ordering. That way they fit properly. If they don't fit properly, it can act as a tourniquet and actually restrict some of the blood flow, and that's not what you want. So those are some considerations in terms of compression stockings. Other conservative treatments for varicose veins or venous disease during pregnancy would be exercise. So walking at a slow to moderate pace, 30 to 45 minutes a day. That has numerous health benefits during pregnancy and really helps facilitate circulation. And another consideration is elevation. So getting your feet up in a recliner on a few pillows. Usually during TV time is a good time to do that towards the end of the day. And, unfortunately, we don't offer any treatments during pregnancy in terms of, non-invasive treatments. We really leave those for postpartum or after you've had your baby. So those are the treatments. They're mostly conservative treatments. And I do want to touch on the next slide here. Just pregnancy is what we call a hypercoagulable state, meaning it's the medical term, meaning that you're just at an increased risk of blood clots. And that's actually a protective part of pregnancy that helps prevent you from having a miscarriage. And it's important to know the signs of blood clots, because if you get a clot in your leg, it could go up to your lungs. Oh, we went back here. I don't know what happened. Oh. It can go up to your lung. It could be fatal to mother and baby. So it's really important just to know the signs of blood clot. Typical presentation would be a sudden onset of warmth, pain, or swelling. Most commonly occurs in one calf. You may have all the signs or just one of the signs. So just important to be in tune with your body. If you're noticing something doesn't feel right, you need to get to your nearest vein center, emergency department, urgent care. You need an ultrasound to make sure that that is evaluated. And just know, once you've delivered your baby, some of this is going to improve. Pregnancy itself worsens this issue, and some will improve once you have delivered your baby, because you will not have the pressure on the blood vessels. And if there are remaining issues after you've delivered your baby and it's some time after, there are treatments we can offer. So I hope you have enjoyed my presentation tonight and have found it informative. And for all of those who are pregnant out there, I hope you have a happy and healthy pregnancy. And just these references.
Thank you so much. That was such a great overview, and I love working with you. I think the world of you. You're a wonderful person, and our patients absolutely love you. Couldn't do it without you. I hope to share my screen next. I'm just going to touch on why is it that pregnant patients get varicose veins. So as soon as I can share my screen, I will do so. Okay, I think I'm getting there. All right. Hopefully everybody can see that. And hopefully that looks right. So again, thank you everybody for being here. Why is it that pregnant patients have varicose veins? The way I think of the arterial and the venous system, they're long highways. Blood goes from the foot back to the heart against gravity in the venous system. And these are somewhat busy slides, but they kind of show you what the blue obviously is the veins, and the red are the arteries. And in the pelvis, you can see that these veins are very deep inside. They come in from the groin and then go almost back into the pelvis and up the spine, where they become the vena cava, which is the main blood vessel going back to the heart. So as Jessica was alluding to before, you know, if somebody develops a deep vein thrombosis or a DVT, that could potentially break off and go north, which would be to the lung. There's a lot of people in the world that suffer with varicose veins. It is actually much more common than arterial disease. We hear a lot about arteries and about heart attacks and those kinds of things, but actually varicose veins and venous insufficiency are more common than arterial disease. Patients can present with anything from pain and swelling to open ulcers. I'm not going to talk much about blood clots right now because Dr. Harth will discuss that at length. What I tell patients is the way we were created is that there are these one-way valves that allow for blood to flow in the upward direction against gravity. So blood is coming up, and if the valves are working properly, the blood cannot pool. In an unhealthy vein or a vein with venous insufficiency, the blood pools in the downward direction when these valves don't work. So as the baby grows, as Jessica pointed out, and as it gets bigger, it takes the space inside the pelvis. And again, if this is the uterus, I don't know if you can see my little pointer, but here's the uterus. As the uterus grows, the veins are here in the back and they can get compressed. And I think about it as, you see all this water, it's like a dam and it shuts the veins shut so that the blood or the water in this particular picture gets backed up, if you will. And that also leads to increased swelling into the venous system in the legs. The other important factor in pregnancy is that the blood volume increases upwards of 4 times of normal. There are hormonal and chemical physiological changes that can increase the risk of blood clots. And that's a whole discussion in and of itself. And there are these physiologic changes to the blood vessel walls that make them leakier, again, leading to more problems with swelling and so on. And of course, there are patients who have genetic reasons to get varicose veins or venous insufficiency. It can be inherited as well. The good news, as Jessica pointed out, that the fluid imbalance is usually resolved by 6 weeks after postpartum. The pressure from the growing fetus is no longer there because the baby's been delivered. And many of the varicosities regress or get smaller. And again, the varicosities can be anywhere in the leg, in the vaginal area, and certainly in the pelvis as well. And there are many procedures that we offer that will help if the varicose veins remain symptomatic, but usually we recommend waiting until the mom is done breastfeeding, again, because we use medications during these procedures that could be harmful. So the wonderful thing about having a baby is that they then grow into wonderful young people that we can be proud of. Thank you very much. I'm going to stop sharing my screen now, and Dr. Harth will share with us next.
Great talk, Jessica and Kathleen. Thanks so much. Let me try to make sure I can share. Not almost there. While I wait, it's really just an honor to be here, and thanks so much for the invitation. I'm really happy to share hopefully some useful information for all the moms or future moms out there, or if you know a mom. And certainly I learned and refreshed my mind as I was preparing this talk and thought, wow, if I had known all these things when I was pregnant and had my 2 C-sections and my 2 babies, I might have maybe walked some more and worn my compressions more.
I agree.
So I'm still not able to share.
Okay. While
I did send you my talk, Kathleen, if you maybe pull it up.
I have it too. Let me see if I can pull it up.
I sent an updated version like about half hour ago. Oh, wait, no, there it is.
Oh,
Okay, I'm good. Here we
oh,
go.
you got it?
Good job.
Okay, can everybody see that?
No. Yes.
Okay, perfect.
Yes.
So I'm going to talk about venous disease and pregnancy, and specifically about some of the medical emergencies. And really this relates to clot formation, as already Dr. Ozsvath and Jessica have mentioned. It's a state of hypercoagulability or clot inducing state. And so we'll talk a little bit about what it is that makes us more prone to forming clots during pregnancy, and what are some of the risk factors. So we want to highlight and increase the awareness of risk factors so you can empower yourself with really knowing the kinds of conversations you want to have with your doctor. If you are, maybe to ask and wonder if you are at increased risk, if there's a family history, you want to understand the implications of any risk factors that you may have, and things that you and your provider can discuss and weigh out the risks and benefits of. In the event of a clot, there may be indications for therapies, and most of these therapies are medical. And there are very unique and special and less common situations where you may need a procedure. And again, all of those need to be discussed with your provider based on your particular situation and the risks and benefits of any of those therapies. And so I think really the goal is that through an early identification and management, you can keep yourself and your baby healthy through this process. So globally, all the conditions are known as venous thromboembolism or clot formation. And what does this mean during pregnancy? It's the leading contributor to maternal morbidity and mortality, so poor outcomes and survival. It's the most frequent cardiovascular complication encountered in pregnancy. And relative to the general population, pregnancy has a 6-fold higher risk of having a clot event. So not a small difference compared to the general population. For every 1,000 deliveries, 1.2 clot events will have occurred. The risk increases throughout pregnancy. So as you go from first to second to third trimester, the risk increases. And perhaps, again, something that really kind of struck me, which I wouldn't have thought, but it actually continues into the postpartum state. And it peaks around 2 weeks after delivery and can continue as far out as 12 weeks. So very important to keep yourself really healthy, mobile, and engaged during this long process of keeping yourself and your baby healthy. And so I'm going to talk about 3 types of clotting events. And they can be broken down into those that occur in the superficial system of the legs, which are known as superficial thrombophlebitis. And those can occur in the visible varicosities or in another superficial vein that may be just a little bit deeper to the skin that you can't see but lives in that space outside of the muscle. Then there's deep vein thrombosis, which is generally, again, will specifically mostly focused on legs. But these are the veins that are deep to the muscle, in the muscle, and drain through those large pelvic veins, which we just saw some anatomy for. And then we'll focus on the last one, which is the most critical and significant event, which is a pulmonary embolism, or when a clot dislodges from the legs or somewhere along the pipes of our venous system and travels up to the lungs. And so this is certainly a challenging and a concerning problem. And so why do we form clots during pregnancy? Well, as already alluded to, it's what's called a prothrombotic state. We are in a clot forming state during pregnancy for multiple reasons. Jessica mentioned one of them, keeping ourselves from bleeding and keeping things safe. So we have increased clotting proteins that are created and formed during pregnancy. There's decreased venous flow for those obstructive causes in the pelvis from the growing uterus and the growing baby. Our hormones dilate and distend our veins and our vessels to accommodate for all the blood volume and the swelling that will occur in the growing pelvis and the baby. So we want to stretch because we want to fit everything in there. And these can compress the important anatomic locations in the pelvis with the deep veins and drainage of the blood out of the legs. And so in general, these can account for up to 11 of clot formation events in pregnancy. As mentioned, we have more blood volume, so increases in cardiac output occur during our pregnancy. We gotta get blood to ourselves and the baby. This goes along with an increased blood volume and a significant hormonal changes. So what are some risk factors? Let me move this. This may be in the way. Okay, so some risk factors, as we could see here, in the top right, can include a personal history of a blood clot event, perhaps a clotting disorder event. Age is a risk factor, so over 35, increased BMI or being overweight, lack of mobility, not moving, getting up and walking every day. Those are really important. Multiple pregnancies, diabetes, then we get into medical causes, early pregnancy with preeclampsia as a risk factor, having a C-section versus a vaginal delivery, blood pressure issues like hypertension, diabetes, smoking, and other conditions can increase the risk. A prior history is particularly important, and whether it's one that was provoked, so in the setting of an accident or a surgery, versus one that we would call unprovoked, that happened for really unclear reasons. Those put you in very different risk categories. And so in this scenario, if you become pregnant and have a history, it's really important to talk to your provider, as this may be a unique situation where you may want to get some testing done to evaluate for why you may have had that clot if you haven't already had it. As mentioned earlier, the risk really changes over time. And in this bottom right of the screen, I just kind of put everything a little bit in order to understand how much each different topic here, risk factor, increases the risk of a blood clot. So first and second trimester is associated with a twofold risk of forming a clot. Undergoing assisted reproductive technologies like IVF also increases your risk because of the hormone changes and needs of that process. An abortion also has a twofold risk. And as we see here, family history can contribute a fourfold risk. As we get into the third trimester, there's a ninefold risk of having a clotting event. And then if you have a history of a clotting disorder, a 15-fold risk. And here's that part that was, again, sort of a shocking reminder that even after delivery, you can have up to an 80-fold risk of forming a clot event. So again, very important to keep that in mind, that even after delivery, you have to really just be aware of what the symptoms and signs may be so you can get early care. C-section versus vaginal delivery has a 5-fold higher risk of a clot formation. And in general, it's thought that most patients who have a C-section or require C-section have it for some conditions, or going into early term, or maybe certainly comorbidities can require you to have a C-section. And so then you wonder, well, if there's such a risk associated with pregnancy, well, why are maybe we should all, when we get pregnant, go on a blood thinner? Well, it's not quite that simple, and there's certainly considerations for why some medicines may be risk factors. There's things to consider, like unpredictable labor, or the needs for an epidural or medications where you can't have blood thinners. And then it's just that most of these medicines are not safe during pregnancy. And so there's very few medications that are approved for both keeping the mom and the baby safe. So in general, and for multiple other reasons like allergies and effects on our bones, such as osteoporosis, there is no benefit to going on a prevention dose with no prior history or no prior event. Certainly if you have a prior history or other event, this is a situation where, again, in conjunction with your provider, you may be in the group of higher risk and be a good candidate for prophylactic dose or other types of dosing. And this just kind of shows some of the dosing that may be available or discussed with your provider, some of the limited but optional medications, the most common being Lovenox, which is an injectable medication, which can be given during pregnancy and not transfer into the fetus. And so these are just some things that are important to keep in mind. And so again, the three being the superficial system or the superficial vein thrombosis, deep vein thrombosis in the legs or the deep veins, and pulmonary embolism when the clot dislodges up to the lungs. So real briefly, a superficial event occurs in the surface, close to the skin. As described, it can be associated with pain, heat, skin discoloration, more common in the legs and the arms, and importantly, often confused with cellulitis or an infection because it can be quite red and quite painful and hot. But it's important to identify these correctly as it actually has implications for how you may be managed. The diagnosis is clinical. A non-invasive ultrasound evaluation can provide further information, and these are nice and easily readable in an emergency room or perhaps in an outpatient office or vein center. Higher risk characteristics are known, such as if this event occurs in the thigh or above the knee, if the length is long, like greater than 5 centimeters, or if it's close to that connection between the superficial vein and the deep vein, known as disjunctional area, and that's generally in the groin or behind the knee. But if it's close to that deep vein, that's another risk factor. And this may change how your provider takes care of you, meaning you may need blood thinners. And so this is a consideration, an event where you may consider going on a blood thinner or being put on a blood thinner to prevent really progression of the clot into a DVT and then the subsequent risk of PE. So we'll then briefly describe DVT. So this is in the veins deep in the deep muscle. Also can present similarly, but with less kind of obvious leg changes. And not that they all have the leg changes, but most of the time you'll have leg pain or swelling, and it's usually unilateral. And again, this is due to that compression in the pelvis. And so relative to the non-pregnant population, we also see in women that are pregnant, if they have a DVT, it's mostly in the what we call the proximal or the larger veins, meaning in the pelvis or the iliac vein and the femoral vein in the thigh. So more commonly occur in these larger veins due to that compression in the pelvis. Also diagnosed with ultrasound and a clinical exam. And the treatment, again, if it's there, is a blood thinner. In this case, you need anticoagulation. So seeking care early is very important. Now, there are very few and unique scenarios, less common scenarios, where you may need an intervention or a procedure to remove the blood clot. And really, we reserve those for limb-threatening events. So if you see this picture on the bottom right, it's a much more dramatic representation and skin changes in the leg, which is more purple and congested on this picture. This is the left leg. And this is called phlegmasia ceruleum dolens. And so certainly this is more of a limb-threatening emergency. And in this case, there would be extensive discussion with your provider about your options, how to keep yourself safe, your baby safe, as these therapies usually involve blood thinners, continued blood thinners at higher doses during the procedure, as well as radiation. And finally, pulmonary embolism. And this is really the most, the one that really contributes to maternal mortality and fetal mortality. And so this is the most severe of the three, the less common of the three, but it is the trickiest to diagnose. And so really, this one becomes quite challenging. So it's thought to contribute to 1.5 per 100,000 maternal deaths in the US and Europe, being the leading cause of maternal death in developed countries. In the US, it's the 6th leading cause of maternal death. And the highest time is in that postpartum period. So again, keeping ourselves in tune with our body and how things are going in our postpartum period is very important. What contributes to these outcomes or poor outcomes is really, it's just a delay in diagnosis, the challenges of diagnosing these, delays in treatments, perhaps a missed DVT or progressive SVT or superficial vein thrombosis. Those are thought to contribute to some of these outcomes. Presentation relates to breathing. This is a blood clot in the lungs, can affect the breathing in the heart. So fast heart rate, fast breathing, shortness of breath, swelling, chest pain can be presentations. And the challenges are in diagnosing is the testing. Some of this testing involves radiation, but you can start off with some blood work, maybe an ultrasound of the heart to see if your heart is strained or obstructed by the blood clot as the blood moves from the right to the left ventricle. There are scores that are usually used in the non-pregnant patient, but they're very challenging to use in pregnancy, and they haven't really been validated. And those sometimes help us stratify patients into buckets of higher and lower risk, and should we treat or not treat. And generally, if there's a high index of suspicion and it appears that you may be dealing, your physician may be dealing with a pulmonary embolism and you may be having a pulmonary embolism, then we would just start anticoagulation until we can get further testing. And again, and what about a procedure? So we're still talking about just blood thinners. There are rare scenarios where the blood clot is so large that it affects the blood pressure, it affects the heart function, your oxygenation, and these are the scenarios where an intervention is life-saving. And certainly high-risk procedures that also are associated with a high mortality for both mom and baby. And so these need to be addressed very quickly and presentation to the emergency room. And when I talk about medications, I think the most common one, as long as there's no allergies or other contraindications, is Lovenox. That's the safest one in pregnancy and in the postpartum state. Does not cross the placenta, does not cross the breast milk. It can be given in prophylactic or therapeutic higher doses to treat an actual deep vein clot. And really important to note, as our weight changes, both during pregnancy and after pregnancy, this medication would be adjusted as it's weight-based, so we want to stay on the right level of the dose. Other medications can cause harm to the baby, such as warfarin, so those are not given during pregnancy. And other medications that you may have heard of that are easier to take because they're pills and don't require checks, those don't have a lot of data safety evidence for mom and baby, and so they're generally not used during this time period. So in general, pregnancy is associated with this group of disorders, clotting disorders known as venous thromboembolism. They're the leading contributor to maternal mortality and morbidity. Pregnancy is a state of high risk for clot formation and even higher after delivery. If there are no risk factors and no prior history, really it's just important to stay healthy and active during your pregnancy and after delivery. If you have risk factors or prior history, really discuss these early with your provider, assure you are being managed properly and keep those in mind. It's a shared decision-making process between you and your provider about risks and benefits and your options. Diagnostics, medicines, and interventions all need to be considered if appropriate, as they can have there are risks and benefits to both mom and baby. And most of the events can be managed medically with blood thinners, and there are just these unique events that are both limb and life-saving that would put you in a situation where you need an intervention to prevent death of you and the mom and the baby and keep you alive and healthy. And so with that, I'll wrap it up, and thank you so much.
Thank you. This was amazing 3 presentations. I think this is so needed. And of course, it can sound scary to the patients, but the takeaway is that the most pregnancies put you, have physiological changes. You will have, fluid overload and etc. But these rare events, you should just know about it, but know how to seek for help. And thankfully, they're rare. I think that the takeaway for me in terms of like the risk of the emergencies is like, the DVT risk or the thrombosis risk continues after the baby is delivered. And I think even myself, I was like, I had a swollen leg right the week after, and I'm like, I need to have an ultrasound done. I did not know it was 80 times higher at the time. I think I should have known that, but anyhow. But I think I have a question in terms of all of us managing patients with vein disease, and also like pregnant patients. What is the most common thing that you observe in terms of venous disease during pregnancy and afterwards? And I guess I'll start with Kathleen because she's already opened the mic.
So Jessica, you can help me on this one as well. I think in the office, we see a lot of patients that are pregnant who maybe it's their 3rd pregnancy and the varicose veins are now much worse than they were, or patients who have vaginal varicosities that are extremely uncomfortable. You know, and I think that we tend to see that. We also see people with superficial phlebitis, you know, in the office, in the hospitals. That's where we see the patients with the big, you know, DVTs and that kind of thing. Unfortunately, here in upstate New York, it's rare. You know, we tend to see more the patients who complain of, you know, swelling and then, you know, varicose veins that are painful. Jessica, would you agree with that? You're muted, by the way.
Yeah, I agree. Yeah, I'm not sure, you know, what else. I think you covered it. That's, yeah, usually, you know, the types of patients we see. We don't have a huge amount of pregnant patients come into our office. We actually see people who've had many children and are still experiencing pain from their veins.
Yeah. And a lot of times I think that when patients do come into the office, if they're pregnant, we always say to them, unless, of course, there's an extenuating circumstance, that once you have the baby, it's going to get better. But there are a subset of patients where it doesn't. And it leads me to the question for you ladies, Gloria and Karem. We see those patients who've had a lot of children and may have varicose veins within the pelvis. And if maybe you two could comment on how you work that up and how you treat those patients who have sort of the after effects within their pelvis.
Go ahead, Karen.
Sure. So I think that, well, so to start, I think I don't get to see a lot of pregnant patients with varicose veins in the office. And I chalk that up, well, I could be assuming, but I think generally their OB-GYNs are managing their varicose veins appropriately and conservatively. When they do come to me, it's usually after several pregnancies and now they're getting worse. And they're starting, you know, it doesn't feel like that first or that second pregnancy. And now they're like, these symptoms are not the same. Like something, so they're appropriately concerned, and they come in and we do a lot of education. And generally, you know, there hasn't been a phlebitic event. And really it's just educating them on the timing and the appropriateness of when it's okay to intervene or reassess. And so generally, you know, postpartum. And then there's another group of patients, and it's a smaller group of patients. And I think some of this is related to education and, you know, the need for increased awareness about pelvic venous disease. There's a group of patients that will show up in a way that they just haven't been able to get a good answer about why they have vaginal varicosities or why they have varicose veins in near their buttock, in the back of their thighs, or in places that are not typical, or that others have really not giving them good information about. And so then we really start to talk about what are the contributors to pelvic venous disease. Again, we do a lot of education about when there would be, you know, what is considered chronic pelvic pain. What are some scenarios where we may want to think about further evaluation in the very much postpartum, post breastfeeding, you know, way out from pregnancy, and some of the risk factors. So I find myself really doing a lot of education. And the patients who come with pelvic venous disease are pretty far out from a pregnancy, and maybe they had a CAT scan and some incidental findings were noted, and then they were sent my way. And generally, more times than not, they're incidental findings. And I think for me, I actually enjoy talking to those patients because I want to educate them on the fact that just like you can have asymptomatic veins in the leg, you can have asymptomatic varicose veins in the abdomen and pelvis, and we should just watch those and kind of let them be.
That is great takeaway. I think with the utilization of imaging nowadays, I think it becomes very concerning that, you know, some of those findings are incidental and patients don't have symptoms. Nothing should be done. So it's good that they go to see Dr. Harth, and then they know and they get educated about it. But I think most of the time they are just wandering around and trying to get to the right specialist. This is a great summary. I think, in terms of the worst case scenarios of what can happen, and, including I agree with Kathleen, Jessica, that the most common thing that you see in the clinic on a actively pregnant patient is vulvar varices that are, that are hurting and they are dilated. And I think the worst case scenario that I've seen, I guess, in the clinic is a superficial phlebitis or thrombophlebitis that ended up being very extensive. So please, I think, for the patients, if you do feel like there's redness, there's swelling, there's pain towards a vein that is superficial, just look for your physician or primary care and then your specialist. Because unfortunately, some of those situations can be a little dramatic in the sense of the amount of clot that is there, the length of clot, and the proximity to the deep venous system. So unfortunately, I had to put some patients on anticoagulation during pregnancy for the big varicosities that thrombose on its own. Other than that, I have not seen in the elective setting anything other than that. Of course, after the fact, patients come with varicose veins in the pelvis and the legs. But in terms of pulmonary embolism and thrombosis that creates significant symptoms in the leg, I have thankfully done not a lot of interventions because it's not that common, but we are limited. I think Karen already showed this, like for the patients that we're limited in what we can do, but certainly we'll have to go and use, contrast, radiation, and we're still not going to use medications that are not approved, obviously, but we are limited in the amount of medication. So we try to get, the clots treated by aspiration, trying to get them mechanically out and try to open up vessels for you, whether it's in the lungs or in the legs. But thankfully, this is not that very common. But essentially, if you do feel like you have symptoms, chest pain, or like symptoms that Dr. Harth described in her presentation, then definitely look for a hospital, look for the emergency department. Vulvar varices that hurt, like thrombophlebitis, or veins that are feeling hard as palpation, you can possibly call your primary care physician and then get evaluated still. I think that will be sort of a summary for the patients. Any other thoughts into things that you should look for your primary care physician, or things that you should look for in emergency department, and more sort of a rapid attention to care?
I appreciate that. Jessica, can you describe sort of when a patient comes to the office for the first time, whether they're pregnant or they just had a baby, what are the things that you ask them regarding their pregnancy history? You're muted.
We typically, ask many questions. So we'll ask, have you had miscarriages in the past? How many children have you had? We'll ask about symptoms of pain, because many patients come to us with just pelvic pain that's been, nobody can find a reason why they have the pelvic pain. So we'll ask questions about pain after intercourse, bloating, those types of symptoms. Do you have any labial varicosities? Do you have varicose veins on the legs? So those are some of the questions we would ask.
And if for initial testing, we usually do an ultrasound. Gloria mentioned that with some of the more invasive testing that requires radiation, we would not, want to offer that, certainly not electively to any pregnant patient. But the ultrasound in the office, can you just go through a little bit what that experience is like for the patients? They've probably had it on their baby, right? Their bellies, but can you just kind of go through the way you order ultrasounds of the legs and so on?
Are you, referring to for like a reflux study, or just to rule out DVT?
Both or either?
So when patients come into our office with symptoms of DVT or blood clot, so that sudden onset of warmth, pain, or swelling, typically in one leg, we will just do an ultrasound. We have ultrasound in our office. So do an ultrasound. Takes about 20 minutes or so, give or take. And we have that information available right away, which is, wonderful. And then for diagnosis of varicose veins and venous insufficiency, it's a little bit more of a process. Some of it's insurance driven. We'll typically give patients a script for compression stockings and go over conservative treatments and bring them back in a few months for the reflux study or the more in-depth ultrasounds. It looks at all the valves of the veins. It looks at the deep system, the surface vein system, to see if the valves are working correctly. Also, traces and measures varicose veins to really give us an in-depth look at, everything that's going on in the legs.
I think that was really well described, Jessica. I think I'll say that one thing I do see in the office is, so I think primarily the important thing is to rule out any kind of blood clot, right? So whether it's superficial or deep in the legs. And so ultrasound is very, very good for that. I think what sometimes happens is I see a full evaluation for reflux being done in the pregnant patient, which is not the study of choice to rule out a blood clot. It's more extensive, it's more time consuming, it's a lot more compressions and evaluations, more time for the mom to sit there with, on her back, which can be hard. And it's not a good test to use for definitive treatment, let's say down the road. We'd want to repeat it in the sort of when your volume is more back to your baseline, you've lost all that volume you gained during pregnancy. And so you want to, I think those are like two different types of tests. And really you want that sort of standard ultrasound when there's a concern for any kind of blood clot. And that's something obviously your provider would choose for you.
Yeah, that's a great point. And I think aside from the ultrasound evaluation, it's also important to understand that all the conditions that we talked about that could happen during pregnancy and prolong as a symptom or as a disease, such as varicose veins, such as pelvic varices and vulvar or labial varices. It is important to know that at some point in your lifetime, you're going to be treating those. We're going to see any of us specialists and you're going to decide for treatment. And one thing that patients often ask is like, what is going to happen if I get pregnant again? And so if you get pregnant again, you will unfortunately have new varices, not the ones that we treated for you, but you will have new varices either in the pelvis or in the leg. Now, does that mean you should not treat your veins? I think that's often a question. A patient asks me, well, if I want to become pregnant again and I'm going to have it again, so might as well not treat it. I think that's a decision that should be optimized per patient, depending on your symptoms. For example, I think many of you showed a patient with a huge varicosity enlarged in the leg that can be hurtful, but also can thrombose. And so you don't want to be dealing with a thrombophlebitis, large clot thrombophlebitis when you're pregnant. So, and I'm not saying we should treat it. You can have this. I have certainly patients that have waited to get treated until they become pregnant again, and then they treat it afterwards. But I think it's an evaluation that should be taken care with the venous reflux and also regarding your symptoms and what is the prospect of your next pregnancy. But overall, all those treatments are really great. But obviously, if you become pregnant again, there is the same inciting factor that we discussed in the 3 lectures, and you will still have some recurrence of symptoms.
So ladies, if somebody has had a history of a DVT, maybe with their last pregnancy, clearly they're going to be fearful that it could happen again. Is there anything special that you tell those patients what to expect with the next pregnancy?
So I think it depends on their, that's obviously a higher risk state. My way of sort of managing that is I am in very close communication with their OB-GYN, and those are patients that generally are considered high risk, and so they'll have a high risk OB provider, and then we co-manage those situations together, and generally it involves some form of blood thinner. If a patient is hypercoagulable, there's often a hematologist or a blood specialist involved as well, because they're helping to titrate those things. So at that point, as a surgeon, I become kind of the peripheral, hopefully educator at most, and really educate my patient to make sure we're seeing the high risk OB, seeing the hematologist, we're keeping up with all the things that they need in terms of proper medication and proper management. And those are patients, if they're on blood thinners, you generally, the delivery part is a little more planned perhaps. And so educating them on knowing, having those discussions about if you go into early labor or how to plan for your labor. And those are things they talk about with their OB. So that's how I approach those. To me, if someone comes to me and they say I have a history and I hear that they're not having a conversation with their high risk OB, then I'm like, no, we gotta have a conversation with the proper people, because you should probably be on something.
I think that's an excellent point, Karen. And I think you, aside from, you had in your slides patient shared medical decision making. And I think that the multidisciplinary aspect of what we are doing as in our roles, cannot be underestimated. Like, we need really to communicate openly with the OB-GYNs as well as the hematologists and whoever else is involved. Once you have a clot, you commit to a lifetime of, a lot of education and possibly having to see different specialists, which is a good thing for your own protection and for your own healthy, sort of a treatment of possible complications after having a clot.
Yeah. No, I think, it must be very scary, especially for those patients who've had a previous blood clot. But I think that, as Jess pointed out, when we see patients for the first time, we go through that whole history, because I think that what we need to point out is that some of these blood clotting disorders people are born with and don't realize they have it until they have a baby, or until some event occurs and then they get a blood clot kind of out of the blue. But then when we talk to them, we find out that actually mom had a clot, or grandma had a clot, or somebody died of a pulmonary embolism who's blood related. So I think just having that in the back of our minds and asking those questions is important. I think there's one other comment I'll make just in general about blood clots. I think that you both, pointed out that sometimes these blood clots tend to be more on the left side, and that there's an anatomic reason for that. And patients will come to us with either swelling on one side, and it tends to be more typically the left. And some people don't know that they had a blood clot at one point during their lives, but it just so happens that that one leg is more swollen. And as you pointed out, Gloria, that's something that we can work up later after the pregnancy is done and the breastfeeding is done and so on. Because certainly venous disease can cause issue long-term, and something important for people to be aware of as well. I think we only have a couple of minutes left. I'm sorry, Gloria, go ahead.
No, that's a great discussion. I think we covered many of the topics that hopefully patients would like to know. I think that in terms of pregnancy, if you are in doubt about your risk of clotting, just talk to your OB-GYN. I mean, I think that most things are discovered when you're pregnant, and that's, but if you do have a family history, please don't hesitate to share that with your physician. I think that's probably the most important thing you should do.
Yeah, and I do think that in general, we talked about a lot of big things. I talked about a lot of big things and scary things, but it's really just about being informed. And generally, most of these events are symptomatic varicose veins or venous insufficiency of the non-clotting type. So that's the good news. But again, just having an awareness and the power of education to advocate for yourself as a patient or for your family member. If there are risk factors, those are good to get on top of early on.
Well, and as you point out, it's the education part that's so important, so that if there is awareness, then a patient can discuss these questions with their GYN and with or OB/GYN and with, their primary care, whoever that they are going to see. And again, it was pointed out earlier that OB/GYNs are very in tune to this problem because they see it, obviously, the blood clotting and whatnot, and the complications that occur during a pregnancy. So, and as Jess pointed out earlier, and I think Gloria, you did too, that a lot of these patients are already involved in their and their GYN, OB/GYNs do a great job of ordering the compression stockings and so on. But anyway, this was an awesome discussion. I want to thank every single one of you guys for being here and sharing your knowledge with everyone. Gloria, you want to tell us
Yes.
what's next?
Thank you so much to all of you. This was amazing. I learned so much about pregnancy. I'm not going to get pregnant again, but yes, I learned a lot from my patients. But I would like to share with all of you that we're going to do the same webinar with for the Spanish speaker patients with Spanish speakers as well on Wednesday, the 28th in June. It's going to be at 7 o'clock and we're going to send invitations, but we'll do the Spanish part of this webinar in 1 month from now. Again, thank you so much to VLU and also to my co-moderator, Kathleen Ozsvath, and to Lee and Eliseo for organizing all of this. Thank you, and have a good night.
Thank you all. Have a good
everyone.
night.
Good night.
Bye-bye.